Hey, Salim Razai here, and this is a case of a patient with chest pain. So to just give you a little setup here, this is a 58-year-old female. She has a past medical history of colorectal cancer. She's currently on chemotherapy. She actually just started that 2 weeks ago, and she presents with chest pain, shortness of breath, and diaphoresis. Her initial vital signs: blood pressure is 146/64. She's a little tachycardic at 113. Respiratory rate is 15. She's afebrile, and she's satting 100% on room air. This was her initial EKG. Now, this is normal sinus rhythm, but the things that I want to point out to you here are leads 1, 2, AVF, all showing hyperacute T waves, and V2 showing a little bit of ST depression. So cardiology was called, and they recommended medical management with aspirin, nitroglycerin, and heparin. After the patient received nitroglycerin, her symptoms resolved, and now you can see her blood pressure is 111/77, heart rate of 102, respiratory rate of 16, afebrile, satting 96% on room air. This is her second EKG. And those same leads that I showed you that had those hyperacute T waves, you can see have now all normalized, and that ST depression she had in V2 is also gone. So there's definitely dynamic change here. After a few minutes, her chest pain, shortness of breath, and diaphoresis return. This time, she's a little hypotensive. Blood pressure is 95/61. She's still tachycardic at 107. Respiratory rates increased to 18. She's afebrile, still satting 96% on room air. This is the repeat EKG when she started having symptoms. And what you can see is those hyperacute T waves come back in leads 1, 2, and AVF. And you have ST depressions in V2, V3, and V4. So cardiology gets called back. They take the patient to the cath lab, and the cath is completely normal. Shows normal coronaries with no coronary artery disease and a normal left ventricular ejection fraction. So because the patient has this history of cancer, we said, you know what, let's just send her for a CT pulmonary angiogram, and that showed no pulmonary embolism. By this point, we have 2 conventional troponin I's that are basically undetectable. So what's going on here? The patient doesn't have an occlusion myocardial infarction, and they don't have a PE. Well, it turns out that 5FU can induce coronary vasospasm, and that's exactly what this patient was having. The treatment for this is usually you just stop the 5FU infusion and you start nitrates and or calcium channel blockers to help reduce that coronary vasospasm. It turns out there's a whole slew of chemotherapeutic drugs that can have cardiac toxicity. And I created this table as a summary so that the next time you see an oncology patient who's on chemotherapy, you can be thinking about these things when you're worried about cardiac toxicity. So there it is, a case of chest pain. Not all chest pain is going to be acute coronary syndrome or pulmonary embolism. In this case, it was 5FU induced coronary vasospasm. Let me know your thoughts and questions. Thanks for tuning in, and until next time.